Hello, my name is Laura Rossinyol, and in the next minutes I will share with you the results of the Spanish PTEMA trial HEM14 comparing lenalidomide and dexamethasone versus ixazomib, lenalidomide and dexamethasone as post-transplant maintenance therapy. Patients with newly diagnosed multiple myeloma younger than 65 years were included in the HEM12 trial and received induction with 6 cycles of BRD-GEM, autologous transplant conditioned with either melphalan 200 or Bumel, and consolidation with 2 cycles of BRD-GEM. Patients who were at least with a stable disease after consolidation were included in the HEM14 trial and randomized to receive maintenance with lenalidomide and dexamethasone or ixazomib, lenalidomide and dexamethasone. Each cycle lasted 28 days. Lenalidomide and dexamethasone arm consisted of lenalidomide 15 mg per day on days 1 to 21 and dexamethasone 20 mg per day on days 1 to 4 and 9 to 12. In IRD arm, ixazomib 4 mg per day on days 1, 8 and 15 of the cycle was added. At 2 years of maintenance, patients with negative MRD were discontinued. Patients with positive MRD continued with lenalidomide and dexamethasone for 3 more years. Patient characteristics at screening, prognostic factors such as ISS, cytogenetics, and plasmacytomas, as well as response status, were similarly distributed in the 2 arms. Overall, 22% of the patients had high-risk cytogenetics, 70% were in CR, and 55% had negative MRD at screening for maintenance. After a median follow-up of 56 months, there was no difference in PFS between the 2 maintenance arms. At 5 years, the PFS was 63% with RD and 62% with IRD. The overall survival at 5 years was around 80% in the 2 arms. In the overall series, patients with revised ISS3 had a median PFS of 38 months. There were no difference between RD or IRD in patients with revised ISS1, 2 or 3. Median PFS had not been reached in patients with standard risk cytogenetics in both arms. PFS at 5 years was 62% with RD and 66% with IRD. In patients with high-risk cytogenetics, the median PFS was 62 months with IRD versus not reached with RD. We looked at each single chromosomal abnormalities and found no difference in PFS in patients with translocation 414, 1416, 17p deletion, 1q gain or double hit. There was a trend towards a shorter PFS with IRD in patients with 1p deletions. Similarly, there are no difference between RD or IRD in patients with positive or negative MRD at screening. There was a trend towards a shorter PFS with IRD in patients who had plasmacytomas at diagnosis. Of interest, patients with negative MRD at 2 years discontinued therapy with a low impact on relapse, while patients with positive MRD had a higher rate of progressions despite the fact that they were receiving maintenance with lenalidomide and dexamethasone for 3 additional years. Regarding toxicities, grade 3/4 neutropenia was similar in both arms, 39 versus 37%. However, grade 3/4 thrombocytopenia, 7 versus 16%, and gastrointestinal toxicity, 2 versus 15%, were significantly higher with IRD. 31% of the patients needed dose reductions of ixazomib. Additionally, there was a trend to a higher need of dose reductions of lenalidomide with IRD, while the need for dose reductions of dexamethasone was similar in both arms, 21%. In addition, 10% of the patients required ixazomib discontinuations. In summary, Maintenance therapy with lenalidomide and dexamethasone in patients homogeneously treated with BRD-GEM induction, autologous transplant, and BRD-GEM consolidation resulted in a long PFS of 63% at 5 years from the start of maintenance. The addition of ixazomib to maintenance with lenalidomide and dexamethasone did not result in a PFS benefit in any subgroup of patients. Finally, this could be partially explained by the higher toxicity leading to dose reductions or ixazomib discontinuations in the IRD arm. And this is my last slide. Thank you very much for your attention.